This is now the third randomized trial comparing or evaluating whether PSA can lower the incidence of prostate cancer mortality. And what it's doing is confirming trends or suspicions that have previously come out from the two earlier trials, one being the European randomized study on prostate cancer screening, or known as ERSPC, which is considered the gold standard. The other trial is the PLCO trial, prostate, lung cancer, and ovarian trial done here in the United States. The PLCO trial was a negative trial. The ERSPC was a positive trial in the sense that the ERSPC showed that there was some decreased prostate cancer mortality with screening. The PLCO was negative. So now we have a third one, which is kind of a tiebreaker, but actually clarifies or begins to confirm the suspicions we had. So specifically, prostate or PSA testing increases the diagnosis of prostate cancer. However, it's primarily finding the low-grade cancers that frequently don't kill men, and is not anywhere near as good at finding the high-grade cancers that do kill men. Furthermore, it has confirmed that the pool of potential cancers to find are overwhelmingly the low-grade Gleason 6 tumors, and the ones that really kill men are much more infrequent. So these are the key facts that this trial confirms, and is the reason why the U.S. Preventive Services Task Force was against PSA testing a few years ago. Increasingly, people are buying into the fact that you need to have a conversation with men to let them know their upsides and downsides to screening. Because this was only a one-off screen, in other words, they only got a single PSA, most people will say, or at least the critique of this paper will be, it does not reflect true PSA testing is. However, the underlying trends and the implications of a PSA test are all there. You've seen a stage shift. In other words, with screening, you find that you're finding cancers earlier. You're seeing an increased incidence, especially of low-grade disease. When you add it all up, prostate cancer mortality rates were completely unchanged. And the reason is we are not doing a good job finding the cancers that truly kill people anywhere earlier. We are all now in agreement that PSA is too sensitive a test, and as a standalone screen, it is not functioning well enough. So the U.S. is moving down towards additional blood testing and other types of evaluation to identify the men who truly need the biopsy. We have to develop tools to say whether the add-on imaging or genetic tests make a difference. It's probably the best randomized trial or study I've ever seen of both screening and treatment, both from the scope, the follow-up, and the diligence to the quality of capturing and analyzing the data. Just an extraordinary job, first rate.